Hi, just waiting to go on live with Instagram as always. If it does work, here it is. Okay, thank you everyone. This is another live with myself, Dr. Isabelle Amigues. I'm a rheumatologist and I have a practice called Unabridged MD in Denver, Colorado. And I see patients on telehealth and in person, although I do prefer in person. Those lives are here to teach us, teach you guys something about a rheumatology topic. And I'm gonna share a story today, and if my patient is here listening, so this is for your husband. Okay, so here's the thing. One of the inflammatory arthritis that we deal with as a rheumatologist is called gout. Okay, gout is a very, very inflammatory arthritis. So it's the worst pain you can have ever. You wake up usually with the big toe that's extremely red, painful, swollen. Even the touch of a sheet is extremely painful, okay? That's the worst. And then it can actually lead to chronic arthritis where there is no in-between episode where you're fine. At the beginning, maybe you had a little bit episode here and there, maybe once a year when you're doing a lot of eating of red meat or seafood or, like just a lot of beer. And then after a while, if you don't take care of it, you can actually develop a full-on blown erosive arthritis. And so this is the story, is that my patient basically is doing really well from her perspective, right? My patient, she's taking care, congratulations, all the work that you're doing. By the way, really, really, really good. I'm so proud of you. Yet her husband or partner, let's put it that way, is having so much pain, but would rather not see a doctor. And so this is for you, right? And I think that there's more than just one person like this. If you have gout, don't let it go untreated. Why? Okay, so what's the issue with gout? Gout is basically you either make too much uric acid or you don't get rid enough of uric acid. So, for example, someone that has a kidney issues is going to build up too much uric acid and it's going to stay in you, right? And then you can actually so you can have too much uric acid because you're not getting rid of it, or you're eating too much high purine diet. That's what we call high purine. So it's basically a lot of protein that when they break down, and that basically leads to a lot of uric acid. And after a while, you can actually develop tophi. Tophi are some nodes that you can have under the skin. So very often we have them here on the external surface of the elbow. You can actually have some on the ear, which I've always find very interesting, that there are some whitish nodules there, like just white spot that you shouldn't have. And then you can have them everywhere. You can have them on your fingers, you can have them on your toes, and so on. And what it is that this is a buildup of uric acid. And it's kind of like reservoir of uric acid. If you have this, then that's just really a sign that your gout is fully uncontrolled. And what happens when you're doing a tough man, I'm going to call this the tough man syndrome, because you guys, and I'm really saying you guys as you men, can handle a lot more pain in general than women. And I'm not saying this as a woman, and I'm literally saying this because I see it in my practice. I do think that women take care of our bodies a little tiny more in general. It's a big generality, of course. But then when we have pain, we ask for help. Whereas men are like, no, I'm not going to ask for direction. I can figure this map out, right? That's the story. When I was in France, would be in a car with 3 other guys. None of them wanted to ask the direction. They were like, we're going to figure it out. After 1 hour, I'm like, hey, hold on. We can ask someone at a bar here that knows the area. And fair enough, we were on our way in a much faster way, right? This is the same thing. The problem with gout is that and I understand you're trying to take care of it on your own and you've looked at internet and you're like, okay, if I don't eat this, if I don't eat that, if I take this, if I take that, if I take some anti-inflammatory, and so on. Sometimes that works, and that's great, right? So you can eat a low purine diet. That's wonderful, excellent, beautiful. And that's all you need, and that's wonderful, right? Or you've been put on diuretic, which is a pill to make you pee because you have some little issue with your heart or something like this. But great. And then you're like, okay, I want to take this off. Maybe there's something else we can do for your heart, or for whatever reason you were on this diuretic. Sometimes for hypertension, we give that. Okay, great. So we take care of this. You're taking care of a diet. Great. The problem is sometimes that is not sufficient. And then why would you continue to have pain? Why would you continue to have this inflammation that's causing issues in your whole body? Because yes, you're a tough cookie and you can deal with the pain, which I'm so impressed by you for dealing this pain. Like, we literally learn in medical school that this is the worst pain anyone can ever have. So kudos to you if you can deal with that pain, but it is not worth it. And what I mean by that is that yes, there's the pain, but there's also all of the things that are being done due to the gout. So just to give you some ideas, right? So we just talked about the fact that it can actually build up in the skin. We talked about the fact that it can erode your joint. So you can actually have erosion of your joint and then deformities of your joint. So we're not just talking about pain here. We're talking about disability and the ability of using your joints. That's a problem, right? Then it can actually cause issue with your heart. You can actually, we know now that high level of uric acid is not good for your heart and your vessels. I mean, that's, number one reason why most people die is a heart issue. Maybe not, it's one of the, top 3 cancer, heart disease, are some of the top 2 medical conditions. And we can prevent that. Great. And then finally, it can cause kidney issues. So it can, like I told you, when you have kidney disorder, you can develop gout, but at the same time, that actually causes kidney issues. So, maybe you have had a stone, a urinary stone, that's extremely painful. Well, those urinary stones are due to this buildup of uric acid. So my question to you now is, why would you not ask for help when us rheumatologists can help you? So in my practice, overall, within 4 months, we put patients in remission of their gout. What's the goal of gout, gout treatment, right? Our goal is to lower the uric acid to the goal of less than 6 if you don't have tophi, or less than 5.5, usually 5 milligram per deciliter if you have tophi. Why? Because if you have those tophi, those nodules, we know that you have more reserve and we need to take care of that, okay? And it's gonna take a little bit more time to make sure that you don't have flares when you have tophi, and the goal is to get rid of those tophi. So that's the goal. The thing though, and that's the problem in the vast majority of cases, and this may have happened to you, the thing is that very often in primary care setting, especially right now where they have only 5 minutes to see you, they forget to tell you, and maybe they don't know themselves, it's totally possible, that if we move the uric acid, you will develop flare. Most likely you will develop a flare. So the typical example is, I'm coming to see my primary care physician saying, I have a gout. I'm pretty sure my toe is super inflamed. Maybe we checked, uric acid is very high. Maybe we've checked, we know that you have tophi, so that's like a definitive diagnosis. Or maybe we've taken some of the fluid out and we saw that there's a uric acid crystal, okay? And you're coming to your primary care physician, or even the urgent care, or even the emergency. And what they do is they're like, oh, your uric acid is super high, we're putting you on allopurinol. And then you develop more flares and you have more pain than you've ever had, because they forgot to add something to stop the flares. And that is the issue, is that you cannot just give yourself allopurinol. If you do that, you're moving the uric acid, and any movement in the uric acid, whether it's up when you're eating a lot of meat, red meat, or anything high in protein, up, or done will cause potentially some flares, any movement, right? And so then what do we do in rheumatology? So I'm just gonna give the one of my last patient. Sorry, I have a runny nose. um, One of my patients who came in not so long ago, actually, well, I think it's been 6 months. He had, like, he's doing really, really well now, and he had this really severe gout. Okay, and like he couldn't move, like even moving was awful, and he had pain everywhere, and he couldn't do anything. And basically, what we started doing is that we said, okay, we need to decrease the uric acid because you're like it's over 10. It was 12. We absolutely need to decrease this, and at the same time, every time you have a flare, we are going to, we're going to prevent the flare. We're going to give you, in this case, we are giving colchicine. Some people can give anti-inflammatory. And if you have a flare, you need to let me know. You can also, we can give the idea. So for example, if I don't know the patient and it's the first time, I will say, okay, we start allopurinol and then we add colchicine, and so it's once a day unless there are contraindication and there are, adjustment. And then what we say is that if you have a flare, you take 3 tablets one day, the next day you take 2, and the day after you take 1. The truth is that sometimes you can still have a flare despite that. So then we have other things that we can do, okay? That's really important because we need to adjust the allopurinol dose, or, we have other treatment, but treatments that are going to decrease the uric acid, we need to adjust that with the uric acid level. So we check uric acid every 2 weeks, and we go up on the allopurinol depending on the uric acid. So every 2 weeks, we have a blood work to check how much is the uric acid, because our goal is less than 6 or less than 5 if you have to 5, right? And then, and that's where it's so important to have your rheumatologist at at your fingertips, if you're texting or on the phone, is that if you have a flare, yes, you can, do the 3-2-1 of colchicine, but we have other options. Sometimes we give a little bit of prednisone, which is steroid. Sometimes we give a little bit on anti-inflammatory. We can take care of those flares so that you don't have all of those pain. And the goal is for you to reach the full goal of that uric acid, okay? And so then once we reach the uric acid of less than 6, normally, after a while, you may still have a little bit of gout flare, but normally after a while, you have no more flare. And then after 4 months of no flare on both in this case, colchicine and allopurinol, then you can back off from the colchicine. Okay, and then, so now can see, right? Like the goal is then, if you have tophi, if you have those nodules, the goal is that those have to go away completely so that there is no more reserve of uric acid, that, too much uric acid. And so sometimes it takes a little bit more time because those are actually going to melt. And as they melt, they need to go somewhere. And sometimes it can cause a flare. So same thing, we're going to take care of this as well. This, honestly, so since I have this practice on Average MD, where I can see patients every 2 weeks, I can talk to them super closely, right? I've seen, like, when this patient who had a uric acid more than 12, normally, if I had been in a previous practice that was insurance-based, I probably would have offered them something called Cristexa, which is a biologic that's very, very, very expensive, but works really wonderfully by melting the tophi. But 1, it can be associated with some pretty severe reaction. And 2, it's super, super expensive. And then 3, it's IV, it's a biologic, so on. So, there are some consequences to that. I, in my head as a physician, I have a full plan of this is gonna, like, if this doesn't work, what do we do next? What do we net next? And I know where I'm going. I usually share this with patients from day one. I try not to overwhelm patients, of course. But, we have, like, we're going to try allopurinol. If that doesn't work, we'll go to Cristexa. If that doesn't work, what do we do, etc. Right? And so I was actually shocked to see that the uric acid went from 12 to full remission, like to less than 5, because he had to 5, within 3 to 4 months. And the reason for this is that we adjusted the allopurinol every 2 weeks, which I could never have done in an insurance setting because we have 3 month waiting time most of the time in an insurance setting. Whereas now in this practice, I am making sure that I have the space to see my patients, and I, on purpose, don't take absolutely like an infinite amount of patients. It's not a numbers game, right? So what I saw then is that this patient basically is at goal of uric acid, and then we started seeing his tophi melt away, and so we're taking care of this. Personally, I think that as soon as he has no more tophi and that his uric acid is still at goal, we can actually start decreasing the allopurinol. And who knows, maybe with just a diet, it doesn't need to be on allopurinol ever again, because he will have taken care of all of his tophi, and he will have taken care of his buildup of uric acid, and maybe the diet at that point is enough. All right. But I think so. It's past 15 minutes. I don't want to take more time. I think it's really important, if there is, one message, is to realize that we are almost in 2025. We have amazing treatments: allopurinol, febuxostat, Crystexxa. They are known. We know how to use them. And it's just a matter of taking care of you and, helping you get to full remission of your gout. That is absolutely doable. And that may, be a remission that's not with treatment forever, which I think is really exciting. And my plea to you is, consider this. Like, give for 6 months, a year, to your rheumatologist and say, I'm going to try. What's the point of having pain if we can take care of it? And remember, it's not just the joint, it's not just the pain. Stop being a tough cookie. All right, everyone. I will see you next week. Hi, Susanna. Hi, Oksanabi. Hi, Rock Doc. And if you're watching this as a replay, please put #replay. Hopefully this was very helpful. If you like this, it's living live on, it's living, all the time, on Rheumatology 101 on YouTube. And you can share. Actually, if you wouldn't mind subscribing, if you can subscribe, that would be wonderful. I'm trying to get to 1,000 subscribers. I think those are actually super helpful. So hopefully they help you and they can help someone that you know. So share the YouTube channel. And have a wonderful week. I'll see you next week. Bye-bye, everyone.